Welcome to the ABIM review on reproductive system. Acute scrotal pain can arise from several conditions. In testicular torsion, pain is in testis, and it's characterized by absent cremasteric reflex. Torsion can have high riding testis or bell clapper deformity. Diagnosis by ultrasound. Now, let's talk about epididymitis, which presents with pain in epididymis, which is relieved by elevation of the sac. Given epididymis is infection, fever, induration, and swelling is present, we need to do urine culture and start antibiotics. If doesn't improve with antibiotics, we need to do ultrasound. Last, Fournier's gangrene, which presents with severe pain, skin edema, crepitus, and blisters. CT or MRI is preferred. Surgical evaluation is needed. Varicocele is identified by a soft scrotal mass which decreases with supine position and increases with valsalva or standing. It can lead to subfertility or testicular atrophy. Diagnosis involves ultrasound, which shows tortuous tubes and retrograde venous flow. Treatment includes reassurance, scrotal support, and NSAIDs. Surgical intervention with gonadal vein ligation is only reserved for cases with significant pain or testicular atrophy. Erectile dysfunction is primarily treated with PDE5 inhibitors, ensuring patients are not on contraindicated medications like nitrates. Second-line treatments include intraurethral alprostadil and vacuum erection devices. Testosterone treatment is contraindicated in conditions such as breast or prostate cancer, BPH or LUTS symptom, and PSA of greater than 4, polycythemia, obstructive sleep apnea, and untreated heart failure. Ovarian cancer screening involves CA-125 levels, particularly in women with BRCA1 or BRCA2 mutations. Genetic testing for these mutations should be offered to high-risk groups, including those with Ashkenazi Jewish ancestry or a family history of premenopausal or male breast cancer. Cervical cancer isn't recommended in females under 21 years of age, even if they are sexually active except HIV or immunocompromised. In those aged 21 to 29, we order cytology every 3 years. For ages 30 to 65, cytology and HPV testing are recommended every 5 years. In hysterectomy with removal of cervix, we can stop testing only if last test was negative. In HIV patients, we start testing when HIV diagnosis or sexually active, whichever comes first, and check annually for 3 years, and if negative, then compliance with HIV treatment most likely, and we can do usual screening. In immunosuppression, testing started with sexual activity and done annually forever. Management of ascius involves HPV testing. If HPV positive, colposcopy is recommended, while HPV negative results lead to repeat Pap tests and HPV testing in 3 years, ensuring thorough follow-up and care. Condyloma acuminata, caused by HPV types 6 and 11, presents as genital warts and is managed with topical therapies like imiquimod or cryotherapy or surgical removal. Condyloma lata, seen in secondary syphilis, appears as smooth, moist lesions and is treated with single dose of IM penicillin G. Polycystic ovary syndrome treatment consists of weight loss as the first-line step, followed by oral contraceptives for menstrual irregularities or hirsutism. Letrozole is used for ovulation induction, with anti-androgens added if cosmetic response is poor after 6 months of OCPs. Emergency contraception methods include copper and progestin-releasing intrauterine devices, which are effective till 120 HRs or 5 days, but are contraindicated in infection, like mucopurulent secretion. Obviously no copper IUD in Wilson's AQND, no progestin IUD in breast cancer. Ulipristal can also be given till 5 days. Oral levonorgestrel is preferred over OCPs, given no estrogen-related side effects, and these are effective till 3 days usually. Dysmenorrhea management begins with NSAIDs or oral contraceptives. If symptoms persist after 3 months, then we do combo of NSAIDs and OCPs. If no relief, then further evaluation with ultrasound to assess for adenomyosis. If no USG abnormality, then we need to do diagnostic laparoscopy because of concern of endometriosis. Sometimes empiric endometriosis treatment with GnRH agonists like luprolide can be done. In initial treatment of dysmenorrhea, if there is contraindication to OCPs like migraine, hypertension, or age more than 35 with tobacco use, we can use medroxyprogesterone. Functional hypothalamic amenorrhea results from caloric deficiency and leads to low FSH levels. It causes estrogen deficiency, increasing the risk of osteoporosis and stress fracture. It presents with no withdrawal bleeding after medroxyprogesterone challenge. Lifestyle changes are the first-line treatment with increased calorie and decreasing exercise. Medication with oral contraceptives as secondary options. Stress. Urinary incontinence presents with leaking urine with Valsalva, coughing, sneezing, and laughing. Management by pelvic floor exercise or pessary or surgery. Urgency incontinence management also include lifestyle change and ABU, which is antimuscarinic and bladder training in urgency. Last, overflow incontinence management by identifying issue. Can use cholinergic agents and self-catheterization. Interstitial cystitis causes chronic pain that worsens with bladder filling and is relieved by voiding. Management includes patient education, avoidance of triggers, and oral pharmacotherapy like amitriptyline or pentosan polysulfate. Post-menopausal bleeding requires careful evaluation, starting with transvaginal ultrasound to measure endometrial thickness. If it's more than 4 mm in thickness, we need to do endometrial biopsy. Behavioral modifications are recommended for mild menopausal symptoms, while moderate to severe cases may require hormonal therapy. For HRT, we first evaluate if any contraindication for estrogen like DVT, CAD, liver disease, history of breast cancer/migraines. If estrogen contraindicated, then we do SSRIs. If no contraindication, we need to give in combined estrogen and progestin in patients with uterus, and estrogen alone in patients without uterus. Paget disease of the breast is marked by a unilateral erythematous pruritic lesion of the nipple areolar complex. Diagnosis involves tissue biopsy and mammography, as many patients may have underlying breast malignancy requiring comprehensive evaluation. Adenomyosis and pregnancy can both cause uterine enlargement, but adenomyosis is associated with painful menses, whereas no menses in pregnancy. Even if a patient has tubal ligation, they can get pregnant, if present with new menopause, important to rule out pregnancy. For recurrent UTIs, which are more than 2 in 6 months or more than 3 in a year, daily prophylactic antibiotics may be recommended to prevent further episodes. In cases of limited life expectancy, cancer screening may not be necessary like in ESRD or severe heart failure patient. Women over 30 with palpable breast masses require further evaluation despite negative imaging with a core needle biopsy to exclude malignancy. Usually muscle atrophies, such as those in Becker's and Duchenne, are X-linked recessive. Preeclampsia is characterized by new-onset hypertension with BP more than 140/90 after 20 weeks of gestation, along with significant proteinuria of more than 300 in 24 hours, or protein by creatinine ratio of more than 0.3, or other severe feature like low platelet, than 100 K, elevated kidney or liver transaminases, lung edema, or cerebral or visual symptoms. Management varies based on severity. In patients without severe features, monitor till 37 weeks with delivery at 37 weeks, and in severe cases, we deliver at 34 weeks. Until then, try to maintain blood pressure and use magnesium sulfate to prevent seizures. Eclampsia involves seizures and requires stabilization with magnesium sulfate and immediate delivery. HELP syndrome is a severe variant of preeclampsia, marked by hemolysis, elevated liver enzymes, and low platelets. It necessitates delivery regardless of gestational age, alongside magnesium sulfate for seizure prophylaxis and hypertension control. Acute fatty liver of pregnancy can present with mild hypertension, low platelets like others, but has significant jaundice. It also involves hypoglycemia and coagulopathy, requiring prompt delivery to manage. Intrahepatic cholestasis of pregnancy is characterized by elevated liver enzymes and bile acids, leading to pruritus. Treatment involves ursodeoxycholic acid, with delivery recommended at 36 weeks gestation to mitigate risks. Pregnancy induces physiologic changes that can alter laboratory values, often leading to moderate elevations in alkaline phosphatase, and asymptomatic cholelithiasis also can lead to uncomplicated biliary colic. These changes typically require only supportive care unless complications arise. Pregnant women with HIV should begin combination antiretroviral therapy promptly, regardless of viral load or CD4 count. Risk of neonatal HIV transmission reduced with ART in mom, zidovudine intrapartum, C-section, and post-exposure ART prophylaxis for neonate. If pregnant female with viral load of less than 1,000, she can deliver vaginally as well. Pregnancy thyroid management involves increasing levothyroxine dose by 30% for hypothyroidism. Recheck TSH every 4 weeks and adjust per trimester-wise numbers. In hyperthyroid conditions, maintaining mild hyperthyroidism with propylthiouracil in first trimester and methimazole in second and third trimester is recommended. Pyelonephritis during pregnancy can lead to serious maternal and obstetrical complications. Management involves inpatient intravenous antibiotics until the patient is afebrile for at least 24 hours, ensuring effective treatment and recovery. Managing gestational diabetes involves maintaining specific glycemic targets, like fasting glucose of less than 95, 1 hour postprandial of 140, and 2 hour postprandial of 120 through a combination of insulin therapies. Postpartum screening in 1 to 3 years is crucial, even if postpartum diabetes tests were negative. In patients with history of gestational diabetes, we need to do first trimester screening for diabetes. Vaccination during pregnancy is vital for maternal and fetal health. Recommended vaccines include Tdap, inactivated influenza, and Rho-D immunoglobulin for Rh-negative moms, while certain live vaccines like HPV, MMR, varicella, or intransil influenza are contraindicated due to potential risks. Patients with systemic lupus erythematosus should be screened for antiphospholipid syndrome due to associated risks. Hydroxychloroquine is safe and beneficial during pregnancy, while specific antibodies require monitoring for neonatal complications. Managing deep vein thrombosis in pregnancy involves using subcutaneous low molecular weight heparin as the first-line anticoagulant. Treatment continues until at least 6 weeks postpartum to ensure maternal safety and prevent recurrence. Thank you for watching.